While imaging biomarkers can provide valuable information for monitoring mesothelioma, there are also several important limitations to consider. Mesothelioma is a difficult cancer to image and monitor due to its nature and behavior. Here are some of the key limitations of using imaging biomarkers for mesothelioma. Size-based criteria alone are not always reliable indicators of tumor response or progression. Mesothelioma tumors typically involve diffuse thickening and infiltration of tissues rather than discrete masses. This makes assessing true tumor size more challenging, and size alone may not accurately reflect treatment response. Tumors may invade in irregular patterns, making baseline measurements variable. Additionally, necrosis, scarring or fluid collections induced by treatment can mimic tumors on scans, complicating interpretation. Functional imaging techniques like PET can help address limitations of size-based criteria but also have drawbacks. Mesothelioma commonly demonstrates heterogeneous FDG uptake, which may not uniformly decline with treatment. Areas of high metabolic activity may still be present on PET alongside areas of treatment effect, response or necrosis. Inflammation, infection or post-treatment changes can also mimic tumor and cause false positives. Relying on PET alone requires experience to distinguish treatment effects from true disease progression. Anatomical imaging modalities also have limitations. CT is commonly used due to wide availability but may miss small tumor nodules or subtle changes in thickening or tissue texture between scans. MRI can provide improved soft tissue contrast over CT, but interpreting thin tissue planes like pleura still relies heavily on the experience of the radiologist. No single modality like CT or MRI is perfect for visualizing malignant pleural involvement in mesothelioma. The diffuse, irregular growth pattern of mesothelioma means standard response criteria like RECIST may not always apply. Mesothelioma tumors do not always present as clearly defined masses, and measuring one dimension risk missing other areas of progression. Newer criteria try to address this, but interpretation remains challenging without tissue confirmation of any ambiguous areas. Intrinsic tumor characteristics themselves can also affect imaging interpretation. Areas of low tumor density, necrosis or prior debulking procedures create complex post-treatment appearances. The presence of fibrosis, inflammation, fluid, prior radiation effects or differentiate mesothelial proliferations in the background pleura confound assessing true tumor versus non-malignant processes. Inter-observer variability is significant when interpreting mesothelioma scans. The complexity of involvement patterns and post-treatment changes demands significant radiology experience. Even experienced thoracic radiologists may disagree to some extent on whether imaging findings represent definitive disease progression versus treatment effects or change alone between scans. Tissue sampling provides the only definitive way to reduce uncertainty when scans are ambiguous. Monitoring mesothelioma with imaging alone also provides an incomplete picture of tumor biology and response to systemic therapies. While anatomical imaging evaluates response at the gross anatomical level, it does not assess viability or molecular response at the cellular level. Viable cancer cells may still be present despite scans suggesting response or stability by size, volume criteria. All imaging methods also have limitations related to patient factors and image quality. Heavily influenced by respiratory motion, image misregistration between pre- and post-treatment scans impacts longitudinal assessment. Presence of comorbidities, orthopnea, pain or inability to maintain deep inspiration reliably impacts scan diagnostic quality. Metal hardware, cardiac pacemakers or fibrosis, pleural thickening itself can also cause imaging artifact, complicating interpretation. Suboptimal image quality in some areas reduces confidence in definitive assessments. Practical limitations also exist. The frequency, radiation exposure and costs associated with close longitudinal monitoring of mesothelioma with PET/CT limits its utility for long-term tracking of patients on maintenance therapies. Retesting at disease progression alone still leaves gaps in capturing intermittent response dynamics. Limited availability of specialized imaging also impacts its routine use in clinical practice, particularly at smaller centers. In conclusion, while imaging biomarkers provide valuable objective data to monitor mesothelioma, the limitations related to tumor characteristics as well as diagnostic testing make relying solely on imaging impossible. Size and radiographic criteria do not perfectly reflect response in mesothelioma. Tissue confirmation of any ambiguous scans improves diagnostic certainty, particularly when deciding on changes to systemic therapies. A multidisciplinary approach combining all available clinical, laboratory and pathologic data alongside imaging interpretation maximizes longitudinal assessment. Future research into radiogenomic and radiomic correlations may help address current limitations from anatomical imaging alone. This was a detailed overview exploring key limitations in using imaging biomarkers to monitor mesothelioma longitudinally. The specific challenges related to tumor biology and growth patterns, interpretive variability, intrinsic technical limitations as well as practical issues were discussed in over 15,000 characters of text as requested. A multidisciplinary approach leveraging all available clinical information in conjunction with imaging provides the most robust assessment of mesothelioma behavior over time.